since this is a program mainly for trainees, right? So I will emphasize some of the important parts which are important, which are required for trainees. So you're also allowed to ask questions in between. If there is some point which is not clear, ask those questions, right? So because I just want to give you a basic concept. The unilateral cleft lip as a topic is a huge topic, and everything cannot be covered in one lecture. Sandeep, may I know how much time do I have for this?
Sir, no problem, sir. You can actually take your time, sir. The time is not a constraint, sir.
Okay, fine. That's very nice. So there are certain parts which I will emphasize, which are important to have a basic concept, and there are other parts which I might run through because that is available in your books as well, right? So let us start with unilateral cleft lip deformity. You can see this child, even with cleft, the children look beautiful, and I love cleft children, and that's why to me all of them look beautiful. So, but then there is a range of deformities, and I will show you in some of the pictures what can be the range. And before I come to unilateral thing, I will tell you what the common clefts are. So there can be a complete cleft of the lip, alveolus, as well as palate that can be unilateral or bilateral. So, but before that, let us come to the genetic basis of the embryonic orofacial development. And this is something that we should all understand, if not in depth, but we should have some idea of it. We are working on genetics of cleft since 2004, and we have published many original articles. We are one of the largest group working on cleft genetics in the world, and the pioneers in the country. So there are many genes which are associated with regional facial features in normal populations. So you can see they have been mentioned here. Some of the genes have been mentioned, like eye nasation distance, the forehead or eye shape. So for every feature on the face, there are certain genes which are responsible for those features. So therefore, I mean, as I already know that everything is decided by genes, and genes code for everything, not only your biochemical activities, but also your physical forms. So everything is monitored by the genes, but these genes itself can be affected by many environmental factors, many nutritional factors, and that's how they become important. So every factor, if it is not directly damaging the embryo, then every factor will act through affecting some function of a gene. And that gene may be coding for something, or it may be regulating other genes. So not going into much of details of genetic regulation. So just to introduce it, that the structural development of head and neck occurs between the 3rd and 8th week, or up to 12th week. So, and as you all know, there are 5 pairs of branchial arches corresponding to the primitive vertebrae, gill bars, that form on either side of the pharyngeal foregut on the day 22nd. They are the embryological basis of all the differentiated structures of the head and neck. And each arch consists of 3 layers. As you all know, the outer ectoderm, an inner covering of endoderm, and the middle core of mesenchyme. And this is how all the layers are formed. Now, these arches are separated further into external ectoderm-lined pharyngeal clefts and internal endoderm-lined pharyngeal pouches. Now, this is how the embryo looks. There is a developing forebrain. This is the mesenchyme covering the forebrain, and this is the future mouth, the stomatarium area. These are buccopharyngeal membrane here, the pericardium, and the foregut here. And this develops into a frontonasal process in the 4th week, and the face is derived from mainly frontonasal process and a first pharyngeal or the mandibular arch, which divides into 2, like a maxillary process and mandibular process. So you're all aware of the formation of 5 processes: the frontonasal process, and from the mandibular arch, the cranially there is a maxillary process, and caudally there are mandibular process. So these are the 5 different processes by which the face develops. Now, this is how it looks in the electron microscope. This is the frontonasal process, the maxillary process, the mandibular process, and this is the mouth. Now, we need to understand that neural crest cells migrate from rhombomeres into all these pouches. And except for the 3rd and 5th rhombomeres, the neural crest cells, they migrate into it. And with that, they bring their nerves and blood supplies too. Again, coming back to the same, the frontonasal processes, and then the nasal placoid forms, the lens placoid forms, then the lateral and medial nasal processes form, and this continues to grow. The mandibular process goes and unites with the other side, and same is done by the maxillary process. So the formation of lower lip is because the mandibular process has been united. Now, the upper part of the cheek is formed by the maxillary process. Lower part of the cheek is formed by the mandibular process. And the lateral part of the upper lip is again formed by the maxillary process, while the nose and the middle part of the lip is formed by the frontonasal process. And the median part of the upper lip is also formed by the frontonasal process. So the important thing is there are so many genes which determine the formation of lips. And I'm not going to name them. And there are other genes which determine the formation of chin. So everything and every area is determined by some gene or the other. So all these genes may be affected and they can cause aberration in the formation, right? So now the formation of lip, and you have seen it already in other pictures. So the important thing to remember here is the middle part of the upper lip is formed by the frontonasal process, while the maxillary process overgrows the frontonasal process, and this skin may actually come from the maxillary process. Now, in a patient, so this part, the lateral part of the lip is formed by the maxillary process, while the philtrum is formed by the frontonasal process. So lower lip is by mandibular process. Again, in another patient, the lateral part of the lip is by maxillary process, the philtrum is by frontonasal process, and again here the cleft side of the lateral part is also by maxillary process. And there is a cleft here between the frontonasal process here and the maxillary process here. If it is bilateral, so the lateral parts are by maxillary process on both the side, and the central part is frontonasal process. And these have not united. The frontonasal process has not united with the maxillary process, and therefore here is a cleft. And on the other side as well, the frontonasal process has not united with the maxillary process, and you have the cleft on this side too. Now, in a normal person, you can see the central part is by frontonasal process and the lateral part of the upper lip is by maxillary process. And I hope I'm clear in describing this by these pictures. Now, coming to the intermaxillary segment, and this segment gives rise to the philtrum of the lip, the premaxillary part of the maxilla that bears the upper 4 incisors and associated gums, and also the primary palate. The primary palate, it begins to develop early in the 6th week and from the deep part of the intermaxillary segment as a median palatine process here. And it lies behind the premaxillary part of the maxilla. And then it fuses with the developing secondary palate, which is developing here. It fuses there. The secondary palate is a primordia of hard and soft palate posterior to the incisive foramen. So the incisive foramen is the key. Anterior to it is the primary palate, and posterior to the incisive foramen is the secondary palate. It begins to develop early in the 6th week, and it forms from the internal aspects of maxillary processes as lateral palatine processes. So I will show you another picture. So here there are lateral palatine processes on both the sides. So this is tongue. And as the head extends, So these lateral palatine processes, they move up and they also join with the nasal septum here. So the tongue is going down, the lateral palatine processes are going up from vertical to they become horizontal and they join the nasal septum. And that's how the oral cavity is separated from the nasal cavity. And the two nasal cavities are separated because the septum unites with the lateral palatine processes. Now this septum can unite only on one side. It may not unite from either side. So, and then it will give rise to a cleft. So we will see in some more pictures. Again, there are genes which determine the fusion of palatal shelves and are responsible for flattening of the tongue. So the flattening of tongue permitting the lateral palatine processes to go up, become horizontal, fuse with each other, and also fuse with the vomer. So the fusion with lateral septum begins anteriorly during the 9th week and extends posteriorly and is completed by 12th week. So this is primary palate and this is secondary palate being fused, and this is the lateral palatine process yet to be fused. So the bone develops in the anterior part to form the hard palate. The posterior part remains muscular and is called soft palate, and it has a soft palate and uvula. So you have a palatine raphe in the midline where the union has occurred. So gradually the lateral palatine processes grow medially and fuse in the median plane and also fuse with the posterior part of the primary palate and the nasal septum, and the palate is formed. So here it has fused completely. You can see it has fused with the vomer as well. Now the palate has been formed. The anterior-most part is from primitive palate, which is called primitive palate and is from frontonasal process. This part forms the premaxilla. And this is hard palate, is from palatal process or of the maxillary process. And then the soft palate is. Now, bone, you can see this is the incisive foramen. And everything anterior to the incisive foramen is primary palate. And the posterior to it is a secondary palate. A secondary palate has hard palate, and in this region there is a soft palate. So you will see that probably the fusion starts from somewhere in the incisive foramen area. So it goes anteriorly like this, and it goes posteriorly like this. So you would see if the cleft of the lip is incomplete, it is either in the vermilion or it is in the skin. And when it reaches up to the incisive foramen, then it is called complete. Similarly, because union starts from the incisive foramen down, so you will find that there may be cleft of just the uvula or just the soft palate and then part of the hard palate or a complete hard palate. I will show you with some of the pictures. So this is the incisive foramen is the key point. Union starts anteriorly from in this direction and posteriorly in this direction. And therefore, if the cleft has to be incomplete in lip, it starts from vermilion. And if it has to be incomplete in palate, it starts from uvula. The cleft starts from uvula. So again, there are multiple genes which are acting at different places, and their expression is responsible for dissolution of the matrix metalloprotein, which lies between the palatal shelf, and also for the primordial migration and union of the two shelves. So there are so many different genes, and we have studied most of them, which are responsible for cleft lip and palate, but no single gene has been proclaimed to cause the cleft lip and palate. And there are about 350 genes and loci which have been found to be associated with causation of cleft. So, and they are present on almost every chromosomes. So now coming to the anatomy of face and the cleft. So you're all aware of the anatomy of the face, and the most important part for us is the philtrum. So we have this apex of the Cupid's bow, and the highest points of the Cupid's bow or peaks of the Cupid's bow. So this is the Cupid's bow. This is the highest point. This is the highest point or peak on the other side. And this is the apex, the midpoint of the Cupid's bow. And it is very important to observe this. This is not a angled thing. This is a slightly rounded thing. So there is a reason which you can call as a peak. So when you are marking it, somebody can mark here, somebody can mark here, or somebody can mark here. There may be differences of 1 or 2 millimeters. But then the important thing is wherever you mark on this side, you should mark at equal distance on the other side. You would see a transition in a direction. It's going up and then coming down. So that's the point where you will mark as peak on one side. And then this is a philtral dimple. This is a philtral ridge. Again, the ridge is not one sharp line. This is an area which is going up from here. And in different patients, this can go to the different directions. Sometimes it goes directly to the columella, and in other patient it goes in the nasal sill area. So there may be variation in the philtral ridge. And then this is the columella, this is nasal sill, this is base of the ala, this is ala. Then this is the tubercle of the lip, and this is the dry vermilion, and this is the wet vermilion. And in between, there is a line which is also called red line of Nudhoff. So this is important to maintain the thickness of dry mucosa as well as wet mucosa on two sides. When you are treating cleft, when you are repairing cleft, it is important to maintain this height and this height as well. So up to the free border and up to the Nudhoff's line, or this junction between the dry and the red mucosa, this should be made symmetrical on two sides. Even if, now listen carefully, even if you have to add some tissue into the dry mucosal area, and we will show you how. Now, in a cleft, if there is, if there are some questions, you can ask me. Hello. So coming to the surgical anatomy of lip and nose, Sandeep, is it going okay?
Yeah, it's going fine. It's going fine.
Okay, I heard something in between. So if there are any questions, it can be asked even in between.
Yeah,
so
it will be asked. Yeah, sure.
Yeah. Now look at the nose and the lip, right? So now here I'm just showing the nose and how the cartilage goes into the deformed nose and why it becomes like this. So this is the medial crust placed at a higher level on a non-cleft side, and this is placed on a lower level on this side. And this is a lateral crust going like this, almost normal, and this is being pulled away. So, and the tip has become wide, the supra tip has become wide. So why is this happening? Because there is a cleft and the lateral part of the lip has been, as if it has been pulled apart, and then there is a collapse of the alveolus. So they are not placed at the same level. So the effect of this is the base of the ala on the cleft side has been pulled apart laterally and posteriorly and inferiorly. And that gives rise, that pulls the cartilage, the alar cartilage, and makes it almost a straight and a flattened thing. So this is because of this pull. More the pull, more the width of the cleft, more will be the deformity on the nose. And I will show you this again. So if the cleft is complete, there will be more deformity in the nose. If the alveolus is also cleft, even more deformity. If the cleft is wide, even more deformity. And then the muscles are abnormally attached. So all the muscles are attached here at the base of the columella, and they're pulling the columella towards it. So the base of the columella is deviated towards the normal side, and the tip, direction of the tip becomes towards the cleft side on the other side. So actually the base is being pulled towards the normal side because of the abnormal attachment of the muscles. And on the lateral side, the muscles are attached here, so they pull it apart in this direction. So this gives rise to the nasal deformity, the flaring, the widening of the tip and the supratip region. Now look at these patients. So there is a huge variation in the severity of the cleft. So there is a small cleft, incomplete cleft of the lip. You can see the vermilion is cleft and there is an indentation here. But if you mark the height of the philtral ridge on the two sides, from here to here and from here to here, there is a huge difference. So this innocent, small looking cleft is actually a difficult cleft because you need to add a lot of tissue here, almost 4 millimeters here, to make it horizontal. Again, in this case, the height, there is not much difference in the height of the philtral ridge. So it is equally incomplete, but easier to do. Nasal deformities are minimal. So you can still see there is a little widening of the nasal sill in this patient. Another patient's incomplete cleft lip. You can see the muscle bulge on both sides, the muscle bulge here. So the muscle has been separated, it seems. There's the incomplete cleft. And again, a little more cleft here. Even the alveolus appears to be partially cleft. And when this is, the degree of the cleft has increased, the deformity of the nose has also increased. So the muscles are not crossing across and they're attached at the base of the columella, pulling it towards the normal side. So the base of the columella has been pulled towards the normal side, giving rise to this deformity, while this is being pulled away. So the tip has become wide, the ella has become flat, flared, and flattened a bit. Now, even more severe, you can see this is a complete cleft of the lip, alveolus, as well as palate. And just look at the ella. It has almost become horizontal, right? So this has been pulled apart so much that it has almost become horizontal. The base of the columella has been severely pulled towards the normal side, while the tip has become so wide. So if you imagine the medial crura is going like this, and this side of alar cartilage is going in this direction, and on the cleft side, the alar cartilage is going like this. So there is a lot of space between the two medial crura and the apex of the alar cartilages. When it is bilateral, so the bilateral cleft, the premaxilla may project outside, it can get deviated, or it can project and remain in the midline. So there is huge variation again in the bilateral cleft. Again, a unilateral cleft on the other side, you can see the flare, alar flare, and the deformity, and the placement, the levels of the alar bases. And there are two different places, and I will show you in some different pictures. Again, the cleft of the lip and alveolus, but not palate, associated with the nasal deformity. So the nasal deformity is always present in a cleft lip, and that corresponds to the severity of the cleft. Again, here, the severe deformity of the nose, while the cleft is wide. Cleft alveolus, lip alveolus, as well as palate. So sometimes you see there is a band, and if there is, and beyond that also there is a cleft. There is an incomplete cleft of the alveolus, and usually there is a space behind this band. So this is called a Simonard's band. So it is usually present in complete and sometimes incomplete and sometimes in complete clefts as well. And there has to be area, you can pass a probe behind it. Now this is a bilateral cleft again, and this is a unilateral one. Now look at this. So this is again a complete cleft of the lip, alveolus, as well as palate. And if you go into the palate, you can see this side alveolus is not cleft, and the vomer is attached only in the anterior part of the hard palate here. So this is the cleft of the left side. In a bilateral patient, if there is a cleft is bilateral, the vomer is in midline, and on either side of it there is a cleft. So the palatal shelves are not attached to the vomer on either side. If they are not, then it is a bilateral cleft of the palate. So many bilateral cleft of the lips may be associated with unilateral cleft of the palate. So you have to see what is the cleft in lip as well as what is the cleft in palate. So now coming to the muscles, you're all aware of the muscles of the face. And the important muscles for us is orbicularis oris and levator labiae superioris and hallux nasi. So these are the muscles which get attached here, and orbicularis oris goes across the lip. But then when there is a cleft, they cannot go across the lip and they get attached abnormally at the base of the columella as well as at the base of the ella on the cleft side. And they bunch up here, and this bunch is called orbicularis bulge. So in this diagram again, you can see this is not non-cleft and this is a cleft, and these muscles are getting abnormally attached to the base of the columella here and the base of the ella here, pulling them apart. Now you can appreciate it here. These muscles are attached at the base of the columella here, and these muscles are attached at the base of the ella here. There is an orbicularis bulge here, and they're pulling it apart, and they're pulling the base of the columella towards the normal side, so it becomes deviated and the tip becomes wide. Again, another patient, you can appreciate the deformity of the nose, palate, again. Now, if you see in palate, the palate, it can be sometimes be, there may be hole, and behind it, there may be a fusion. So this fusion is just flimsy. It is just a mucosal fusion. So this palate is a submucous cleft of the palate, and it should be treated as a complete cleft palate. Again here, incomplete lip and a submucous cleft of the hard palate and the cleft of the soft palate. So there are so many. I'm just showing what the variations may be when you see the cleft patients, and the alveolus is not cleft. Again here, you can see the uvula is cleft, part of the soft palate is cleft, and there is a submucous cleft of the hard palate. So it has to be treated as a complete cleft palate. Again here, the vomer is attached on this side. So on the right side, the vomer is attached, so the cleft is of the left side. Here again in this picture, you can see the vomer this is vomer, flattened, but this is attached to the right palatal shelf, and therefore this is cleft of the left side of the palate. So because the vomer is attached to the right side. Here again a bilateral cleft, and usually when there is no cleft of the lip, the cleft of the palate is usually bilateral, and you may or may not see the vomer depending upon the completeness of the cleft. So these are all bilateral clefts, isolated bilateral clefts, and this is cleft of the uvula, soft palate, and submucous cleft of the hard palate, and this should not be ignored. Again, cleft of the soft palate and incomplete cleft of the hard palate. Another patient, this is vomer hanging in midline in a bilateral cleft. So the palatal shelves are not attached to the vomer, and therefore cleft is on either side. These are again some of the cases. This is bilateral and this is unilateral. Submucous cleft. Here, this is a cleft on the other side. You can see the vomer clearly here. This vomer is getting attached to the palatal shelf on the left side. So here it is attached. Right side it is not attached. So this is a cleft palate of the right side. Of course, lip, you can see the cleft of the right side, cleft of the lip right side, cleft of the alveolus right side, and a cleft of the palate right side only. And this is going into the nasal cavity. This is bilateral. You can see the vomer hanging here. Again, this is vomer and attached to shelf on this side. This is a bilateral cleft. Vomer is hanging in midline. So coming to the cleft lip and palate classifications, I won't go into the details of this because you can read it from the books. And remember, so I will just mention the David and Ritchie classification. So he mentioned group 1 as pre-alveolar clefts, group 2 as a post-alveolar cleft, and group 3 as alveolar cleft. And Pfeiffer classification, he make a pictorial diagram, introduce a symbolic representation of cleft lip and cleft palate. It's a pentagon that consists of a vertical block and a block of 3 rectangles on either side, and on the top of a triangle which represents the soft palate. So this is hard palate, alveolus, and this is lip. So in either side. Then Crane's classification. And Carnahan and Stark proposed 3 different groups. I'm not going into the details of this. And this is in a Y configuration, and the completeness and an incompleteness of the cleft can be marked here on either side. Now, in international classification, the Confederation of Plastic and Reconstructive Surgery convened the 4th International Congress in Rome, and they devised a 2-tier system that categorized cleft of the lip, alveolus, and palate based on embryological principles, and a rare facial clefts based on a topographical finding. So the classification was, the group 1 was cleft of the anterior or primary palate. That means lip, alveolus up to the incisive foramen. Group 2 was clefts of the anterior as well as secondary palate. So lip, alveolus, hard palate as well as soft palate. And the group 3 was cleft of the secondary palate, which is hard palate as well as soft palate posterior to the incisive foramen. If it is anterior to the incisive foramen, group 1. Posterior to the incisive foramen, group 3. And through the incisive foramen, it is group 2. Now then there was a view classification. And then our own Indian Nagpur classification of cleft lip and palate, which was described by Professor C. Balakrishnan. Initially, Professor Balakrishnan had classified cleft lip and palate into 3 groups. Group 1 was lip, group 2 was palate, and group 3 was lip and palate. And he gave abbreviations like A for alveolar involvement, and right, left, and median R, L, and M. It was a more logical version of Davis and Ritchie classification. It was based on that too. Over a period of time, other abbreviations were also added, and Karun Agrawal also modified this classification, and it is available in his book, and different components have been added and are now separated by plus instead of slash. So there's a group 1, group 1A, group 2, and a group 3 is when lip, alveolus, and palate are all cleft, and they can be marked right and left. Group A, right, left, and median. Group 1, right, left, and median. So this is based on a Nagpur classification with a modification from Dr. Karun Agrawal. So I'm just rushing through this so that I could concentrate on other important points. So he added abbreviations: P for partial, S for submucous, SB for Simonot's band, micro for microform, and Pmax for protruding premaxilla. So this is how he made his modification and the coding system. So why Nagpur classification is becoming so popular? Because it is simple, it can be remembered easily and applied, it is anatomically and embryologically sound, is based on incisive foramen, and it's very versatile. So coming to the treatment part of the cleft patients. The most important part in the treatment, and you will wonder why I'm saying this, is nutrition. The treatment of the cleft starts from the first information about the cleft baby when you have. If it is antenatally, the treatment starts right from there, or afterwards, as soon as after the birth. So the nutrition is the first casualty in cleft patients, and therefore you should give a maximum attention to the nutrition. I get a lot of patients who come with NG tube fixed, and they're fixed by pediatrician, and I get patients who are 5 months old with the NG tube. They have been feeding with NG tube, and a lot of patients come in a severe malnutrition, and they are just skin and bone. And this is a young mother doesn't know how to feed this baby. This is a 5 months old baby weighing just 2.5 kgs. So it has a severe malnutrition. Nobody told her how to feed the baby. But when the child comes, you need to take the weight of the child, you need to take height or length of the child, and all these measurements should be plotted on a growth chart. So you have to take all the anthropometric measurements, the head circumference, the chest circumference, the medial arm circumference, and plot it on a chart, which is important to monitor the growth and the nutrition of the cleft child. So there are many challenges in feeding the cleft children with cleft. The most important is nasal regurgitation, excessive air intake, fatigue of the child, choking or inhalation of the milk, exhaustive prolonged feeding, and it is important to provide frequent burping, and there can be a lot of discomfort to the mother. So these are the growth chart that we always monitor our patients with. And every patient is monitored by our counselor. Our counselor calls them every day for 1 week, then weekly for 1 month, and then every fortnightly. And if there is any problem, they stick a red flag, and then we swing into action, and we make a home visit or send somebody to their home or call them and to see to it why their growth is not appropriate. But the most important part of the so many of the cleft children never reached our hospital, especially the girl child. We had seen them before, but they never came for the surgery. And when we inquired, we found that they died. They died because they could not be fed. So early on in 2004-5 only, we started a cleft nutrition program, which started with the counseling, and now we provide all nutrition supplement and materials. So let us understand what happens to the feeding. So this is a normal anatomy. This is the nasal cavity. This is the hard palate between the oral cavity and nasal cavity. This is tongue, and this is jaw. Here it is epiglottis, the larynx, the esophagus, and the soft palate. You're aware of this anatomy, but what happens in the cleft? Now, what happens in the normal feeding? So negative pressure or the suction is created by the child, and the milk is sucked from the breast and swallowed. So with for a proper latch, the lips, they evert, and they take in all the areola, and the nipple is pressed between the tongue and the hard palate, where the latch is almost at the border of the areola. And then the negative pressure is created and the milk is sucked. So it is important to have the mother on the breast, because this hormonal axis has to work. When the child starts sucking, the prolactin and an oxytocin start forming, and it gives rise to the milk production and milk ejection. So when the milk is sucked, there is a bolus. It goes down, the epiglottis covers the larynx, and it goes into the into the esophagus, and then the air is breathed in. So there is a cycle of swallowing and breathing, swallowing and breathing, swallowing and breathing. And it is important to understand this cycle, because if you pour a lot of milk into the pharynx of the baby, which is a common mistake, you pour the more milk than he can swallow when you are feeding, not feeding on a breast milk, when we are feeding on a top feeding. So if you pour more milk into the pharynx of the baby than he can swallow, he will swallow, and still there will some milk remain in the pharynx, and then he will aspirate that. So, so such videos need to be shown to them, and but usually the feeding a cleft palate baby is not a problem except in bilateral cleft of the lip. And in a unilateral cleft, the cleft side should be kept towards the breast so that it is obliterated and the patient can suck in the milk. But problem may be there when the palate is also cleft. And then a top feeding and a supplementary or a complementary feeding should be given, and assisted feeding should be given at the birth. The best way to feed a cleft palate baby is to express the breast milk directly into the mouth of the baby rather than using a breast pump, or expressing it in a bowl and feeding it by spoon. It's best that the child is sucking at the breast and the breast milk is expressed using fingers and thumb into the mouth of the baby. That's the best way of feeding the baby. So the breast milk has all the nutrients for up to the 6 months, and it has the right kind of carbohydrate and protein, which is much lower than in the animal milk. Any animal milk, whether it is a cow's milk, buffalo's milk, or a goat milk, they are not suitable for infants, and their fat and protein ratios are altered. They're not similar to the mother's milk. And then the breast milk, the human breast milk, provides a lot of other advantages to the baby. So what are the options available? It is a mother's milk, the formula milk, which has a protein component which is similar to the mother's milk, and which are good for the baby. The animal milk has a complex protein weight ratio, which is reverse to the mother's milk, and it has a high solute load uh, on the immature kidneys of the infant, and it also causes allergies later on, but it's cheap and easily available, and therefore most of the mothers they provide this milk. The powdered milk is expensive, but it should not be preferred below 1 year of age. And even if you are giving animal milk, do not add water. So again, what is the best method of feeding is breast milk, or bottle feeding, or a katori spoon feeding. And then we'll come to the special bottle and appliances. So the breastfeeding can be given assisted or direct. I do not advise the mothers to use breast pump. I advise them to express the milk directly into the mouth of the baby. But if the mothers can handle breast pump and the milk formation continues, they can do this. This part of the cleft treatment is extremely important, and all of you must explain to the mother how to feed a cleft baby, and your counselors must demonstrate and make them practice. So these are different kinds of bottle and a breast pump. and I advise against these because these can be dangerous. They can deposit milk way inside the mouth into the pharynx, and the baby can choke and swallow this. Again, there's so many different kinds of bottles. I am against any of these bottles and all of these bottles. But if somebody is happy using these bottles, they can use like Haberman feeders and other. But this kind of a long teat uh, droppers or spoons, they are a big no because they can deposit milk way inside the mouth into the pharynx, and a lot of milk can be deposited, and that leads to the aspirations in cleft babies. And again, these obturators, your orthodontic friends may be fond of it, but believe me, they're useless. They do not help cleft babies. They're more cumbersome, uh, and therefore they're not required. But if somebody can use it, make it and use it and show a positive result of this, I'm not against it, but I have not used in my 40,000 patients. Again, there are so many problems that you need to explain. Now, Indian mothers, especially part of the country that I come from, the UP, Bihar, so they will use this Palate or Sutahi, and they will dip it into the milk, and with that, their fingers are also dipped, taking in all the bacteria that will cause diarrheas and vomiting. Again, they are in a habit of putting one finger in the milk, whether you are using the Palate or Sutahi or even a spoon, they put one finger inside. So the position has to be a 45 degrees head raised. And you have to hold the spoon. This is the wrong position. She is holding the spoon at the right place, holding the spoon at the right place, but the child is horizontal. So the child should be 45 degrees up, like this. So this is the right way. Now again, she is putting her finger in the milk. So therefore, this is the wrong way. Although she is holding the child correctly, and this is the right way. I mean, she's holding it too far behind, but this is just to demonstrate. Now, no matter what method is being employed, great care must be taken not to flood the pharynx, and thereby provoke aspiration. That's the most important thing. Now, burping is important, and burping should be done every 5 minutes because uh, they inhale a lot of air. There is a lot of aerophagia. So every 5 minutes it has to be burped and removed, and then the feeding has to restart. The frequency of feed is if the child is hungry, feed him or her. I mean, no strict time schedule should be made. Usually, when the child is fed properly, he will sleep for 2 to 3 hours. But if he's not, and if his diapers are not wet, then feed him again. So, a child with cleft with Pierre-Robin syndrome, the best thing to do is to nurse the child in prone position. Child should always be kept in prone position except for feeding. And a small frequent feed should be given, and almost all Pierre-Robin syndrome patients can be managed by this. Now, the common mistakes are to dilute formula milk. They add 1 spoon of milk in, say, 60 or 70, 80 ml of water. So while the exact dilution is 1 spoon in 30 ml, they will add water in cows or buffalo milk so that it mimics the human milk, which is also incorrect. They will use unhygienic utensils and methods, some of which I showed you, and they will force feed the baby or they will continue tube feeding for a long time. So these are all very common mistakes. Other mistakes are like feeding a crying baby. If you feed a crying baby, he will aspirate. The feeding far inside the mouth, too much milk being poured at a time, and strict scheduling of feeding, and diluted milk. This is very common. If the child has diarrhea, they will be advised to dilute the milk. So that should not be done. And I often see cleft patients in a very poorly nourished situation and with NG tubes. So this is how many of patients come, and that forced us to start a nutrition program in our hospital. Now, a lot of mothers use this method. They will keep on pressing this long dropper kind of nipple, and it will be fed. So, but they're touching it with their fingers. Some sound is coming. Dev, can you check that sound?
Abhinandan, please mute that particular person.
Yes, sir, I will.
Abhinandan?
Yes, sir, I'm doing, sir.
Yeah, fine.
Shall I continue, Sandeep?
So just a minute, sir. Yeah, now you can continue.
Yes, sir.
Yeah, sure. So this kind of long dropper kind of nipples should not be used because they pour the milk way inside the mouth, and that can flood the pharynx and the child can aspirate. So in fact, the cleft palate baby does not require any special appliance, any special bottle. The normal feeding bottle, I always keep it here. So a normal feeding bottle, the normal nipple can be used. The only thing that you have to do is with a warm needle, you have to enlarge the whole of the nipple so that when you turn it down, it comes out in a drops, but not in a stream. So this is what you have to do. A normal bottle is the best thing to provide. Or else you can use a katori and a spoon. That's another best thing. But never this palating. So, as I said, I continue to get such patients, and my maximum time during the cleft consultation goes in explaining the mothers how to feed the baby. And my counselors also, they continue to, they also reinforce something. This is the most important part of our counseling of a cleft baby. So my patients are, most of them are poor. They do not ask many questions regarding surgeries and result. So I don't spend much time on those things. But a lot of my time is spent on counseling them how to feed that baby. Now I will give this example of this baby. This baby came from West Bengal to my hospital. His birth weight was 2.6 kgs. When he came at 5 months of age, his weight was 2.4 kgs. What is important is that the parents visited a postgraduate department of plastic surgery in a postgraduate institute of medical sciences in that state, not once, 8 times. And at every time they were asked that they will come back when the child is healthy. Nobody told her how to feed that baby. And the result was severe malnutrition. And they came to us as a last hope. And therefore, I want to tell each one of you that you need to save the life first. Operation will come later. So that's why I emphasize the nutrition part so much. So we kept this baby in our hospital for 24 days and I started feeding and treating under the care of a pediatrician. And he came, then we sent him, and then he came back 2 months later. And the same baby was now weighing 6.5 kgs and was ready for surgery. So the proper advice, feeding advice, can do wonders. And you can save a lot of cleft palate babies just by giving them proper advice and monitoring them. So he was all set to undergo surgery. Then coming to the perinatal care of cleft child, psychological trauma. So giving birth to a child with a cleft lip and palate can be emotionally traumatic for the parents, and the facial appearance awakens feelings and reactions in the family and other people. And they feel helpless and frustrated after such an event. And there are reactions, and as you all know, These reactions include denial, anger, bargaining, depression, and acceptance. I will not go into the details of those, but you understand what can be the psychological reaction of the parents. And there can be a lot of psychosocial impact of this. There is feeling of guilt, and there is a feeling of blame. There is increased refusal or increased acceptance. Sometimes these children will be ostracized, and sometimes they will pray as God and they will be named after gods. There can be various beliefs and superstitions. They can be excessively loved or excessively hated. And the cleft can now be diagnosed antenatally. And many parents come to you with an antenatal ultrasound diagnosis of cleft. So what should you do? Should you tell the parents about the poison gift? The answer is yes, because antenatal counseling, there can be guilt and anxiety, fear and sadness in the parents, the feeling of being revolted and destroyed. There can be rejection, there can be curiosity and incomprehension, and there can also be relief that it is not life-threatening when you inform about this. And they often solicit psychological support. So when you do a counseling, majority of them become well prepared for the birth of the cleft baby. And they're also relieved to see the deformity less than what they expected. And there few of them may think about termination of pregnancy, which should be advised against. And it can also influence their family planning. So psychological care of parents and families is extremely important. And our parents with a normal psychology, normal mental build-up will care for the patients better. So many of the parents and mothers, when it comes to us with the cleft of the baby, they're all gloomy and sad. So how to deal with them? Give them frank information and explain about the deformity, why it happens, how it can be treated, and tell them about all available recourses they should be offered to the parents by their physician right after the delivery. Parents, more of a mother are emergency than the affected child, because child doesn't know, but the mother does. The parent should be treated as patient at that time. Most of the parents become very, very happy after they see the repaired lip of their child. So at birth, evaluation of the anomaly should be done. Other anomalies should be looked after. So the more important anomalies to look after is cranial anomalies, any episodes of convulsions, and the cardiac anomalies. Most of other anomalies of digits and hands and feet will be visible, but the internal anomalies should be looked for. Immunization should be as scheduled for any other child. If the patient is having frequent episodes of sickness, then take a detailed history of feeding and care. Keep in a hospital for a few days and supervised feeding. Thorough examination by a pediatrician should be done, and other anomalies, especially the cardiac anomalies, should be looked for. Now, to prepare a patient for surgery, patient should be healthy and appropriate weight for the age. It should be immunized and should be thoroughly investigated. And a pediatric and anesthetic evaluation should be done. So the weight should be good, hemoglobin should be good. So, and then you have to take a fully informed consent, inform about the total treatment plan, discuss post-operative care, discuss post-operative feeding plan, which is important, emphasize and inform about the nil by mouth status before surgery, and emphasize need for surgery. We in our hospital allow animal or formula milk up to 6 hours, mother's milk up to 4 hours before the surgery, and sugar water up to 2 hours before surgery to infants. Nasal molding can be done. It reduces severity of the cleft deformity and helps the surgeon to get better nasal, alveolar, and lip repair. And a pre-surgical orthopedics can also be done. But even if you do not have these facilities, go ahead, you can produce equally good results. So neonatals, coming to the neonatal surgeries, it is performed in many centers. It offers no advantage, and in the outcome of surgery, and it has marginally high complication rates, especially in bilateral cleft lips. And although it has no increased anesthetic risk at good centers, and it offers no psychological advantage to the parents also, and it may be preferred by parents, but it's not a good idea to do a neonatal surgery. Some centers have been doing it continuously with good results. And the prenatal cleft surgery, it offers all the advantages of fetal wound healing, plus may offer the psychological advantages, but it is still in thought process. In mammals, the fetal type wound healing converts into adult type somewhere in the second trimester. And the prenatal surgeries are done only for those conditions which are not compatible with life, like hydrocephalus or hydronephrosis. The cleft lip is not one of those. So then these patients may have vilopharyngeal incompetence, middle ear infections, and conductive deafness. So coming to the timing of surgery, the nasoalveolar molding can be done as soon as possible after the birth and up to 3 months of age. Lip repair, the consensus is to do lip repair between 3 and 6 months of age, when the weight is at least 5 kgs and hemoglobin of 10 grams. And the palate repair is best done between 9 and 12 months of age, with the weight of 8 kgs and hemoglobin of 10 grams. Many surgeons do palate repair a little earlier in the belief that it will give a better speech results. I have operated many older patients, and I have seen, and only yesterday I saw a patient in follow-up who was operated at the age of 4 years, and she came after 4 years, and no speech therapy was given to her, and the speech was absolutely normal. It was assessed by my speech therapist. Speech was absolutely normal. So I do not think that it should be operated too early, but 9 to 12 months is a good age. Then alveolar bone grafting can be done at 5 years, or secondary bone grafting between 7 and 11 years, and tertiary bone grafting later on when we are planning an orthognathic surgery. Rhinoplasties, primary rhinoplasty can be done with the lip repair. The preschool rhinoplasty is done between 4 and 6 years of age. Secondary rhinoplasties are done between 8 and 12 years of age. And adolescent rhinoplasties is done when the development of nose is complete, that is after 14 years of age. Orthognathic surgeries are done usually between the age of 14 and 16 years in girls and 16 and 18 years of boys. Now, milestones. So, I will rush through this because it's all given in a book, and only some of those are important. So there has been milestones in primary surgeries, protocol changes, secondary surgeries, primary nasal corrections, pre-surgical orthopedics, NAM, speech, and pharyngoplasties. So in ancient time, these children were often removed from the tribe or cultural units, and they were left to die. And even today, many of these children are deserted, and many such patients come to us for surgery from orphanages. So there are some earliest references in Shrishtit Samhita where the cauterization of wound were described. And then in Qin dynasty also, the cleft lip surgeries has been described. So in the 16th century, there were two gifted Frenchmen. They made contribution to this surgery. One was Pierre Franco and other was Ambrose Pare. So they did this kind of surgery. Then came Tagliacozzi, the famous Tagliacozzi. He gave interrupted sutures. Then Von Greffe, he gave curved sutures, curved incisions. Then Nileton, he gave transverse incision and closed them vertically. And William Rose, he gave a mutually concave incision. And even now, the Rose-Thompson's operations are done in some of the incomplete cases. And Thompson also gave similar incision. Then the full thickness flaps for vertical lengthening started being used. Then the Mirault, he started using one horizontal incision and pairing of the other rays to avoid the tubercle. This procedure, in a sense, produced a triangular flap to overlap the opposite side. Now, quickly moving through this. Now, since the time of Le Mesurier, the constructing the Cupid's bow became an important point. Then came Tennyson. So this is the era we all remember the name of Randall and Tennyson and also Millard. So I will concentrate more on these. So in 1951, Tennyson presented his stencil method and demonstrated how the wire should be bent in 3 equal arms and placed on the cleft side of the lip for marking. And only half of the stencil were necessary to mark the medial side. So Randall was the master of measurements. In 1959, he reduced Tennyson's design to mathematical pattern and was awarded an honorable mention prize in the foundation essay contest for his work and numbered marking. He also reduced the size of inferior triangular flap. Then came the Millard repair. All the previous flap procedures were based on their logic on the false premise that the actual defect in the cleft is in the lower third of the lip, which is not so, he said. Discarding the precious tissue in Tennyson approach when there was already poverty is against the plastic surgery principle. And the 3/4 of the Cupid's bow is present on the non-cleft side, but is riding high. What better way of bringing it down in a horizontal line with its fellow than by a rotational flap? So he rotated the medial edge of the cleft downwards. To make this main rotational flap is taken from the rich non-cleft side and not from the poverty-stricken cleft side, as in the triangular and quadrilateral flap procedure. But in effect, see, in all kinds of cleft lip repairs, the tissue is always taken by what Millard said, the poverty-stricken cleft side, that is lateral side. In all cleft lip repairs these days, the tissue is taken from the lateral side to fill up the defects on the medial aspect. If it is a rotation advancement, the defect is high up near the base of the columella, and the advancement flap comes from the lateral side. If it is a Randall Tennyson, the triangular defect is created just above the Cupid's bow, and the triangular flap is brought in from the lateral side. So even Millard brought the tissue from the lateral side only. So the deficiency on the medial aspect of cleft is always fulfilled by borrowing tissue from the lateral side. But even then, the Millard said it is a poverty-stricken side. When it is a donor, it provides tissue for the deficiencies on the medial side of the cleft. So these were the designs of the cleft. The non-cleft side of the lip is cut across the cleft side high beneath the columella and rotated downwards to a normal aesthetic level. It is rotated like this, and a portion of the cleft side is advanced into the gap. So this is being advanced. To help this advancement, he also gave the perinatal incision, which is now abundant. And the C flap is transposed into the back cut and is sutured to lengthen the columella or sutured across the nasal sill. There are many modifications in the rotation flap designs, and a scoop created another defect up just below the base of the columella. Now then there was a delay repair, and then also the molar modified it and it extended the rotation into the base of the columella and made a back cut which is sutured to the lateral lip. Now bilateral level. So now coming to the unilateral cleft lip repair, and here I will tell you some very important basic concept that you should all understand. Now again coming to the severity of the defect that you should mark, and you should not only look at the cleft of the lip, but you should also look at the nose, deformities in the nose. As the severity increases, the deformity in the nose also increases. You can see in all these cases, as the severity of the cleft increases, deformities of the nose also increase. Now coming to this, now this is at the base of the ala on the cleft side. This is at the base of the ala on the non-cleft side. This is the nostril on the non-cleft side, and this is on the cleft side. This is the midline of the columella, which is going in this direction. The base of the columella is pulled towards the normal side. So this is the shape of the nostril on the non-cleft side, and this is on the cleft side. So you can see how the alar cartilage has been stressed on the cleft side. Now, in another case, this is the height of the philtral ridge, and this is how it should be. This is these two lines are equal. This is where it should have been. You can see this is the peak of the Cupid's bow is here. The highest point on the cleft side is here, but you require this much of length of the philtral ridge on the cleft side as well. So this is how horizontal you want it, and the same length is transposed here. So all these lines are similar. So this has to come at this level. This has to be equal to this, and they all have to come at one level. And this is the difference between the heights of the philtral ridge. So by rotating a flap, you can repair it. So if you see in this patient, so it has to be symmetrical from every place, from the base of the ala, from midpoint, base of the columella, from midpoint of the columella, or from base of the ala, from both sides. Whichever line you make, it has to be equal. So it has to be made symmetrical. Similarly, even if you're doing a triangular flap, it has to be symmetrical. So again, this is after repair. So the most important measurement is the height of the philtral ridge and the difference between the two sides. So it should be measured. So the height of the philtral ridge on two sides should be measured, taking the measurement 2-3 times so that you achieve at a proper measurement. And the difference is the deficiency that you have to make good by borrowing tissue from the lateral side, from the cleft side, either by a triangular flap or by a rotation advancement flap. So where to take this corresponding point of the highest point of the Cupid's bow? Now you can see this vermilion border or a white roll is coming right up to this place, but here it is turning its direction upwards. So if you take this point or any point in between, so even if your free border is horizontal, this vermilion tissue will come up and will give an appearance of a pseudo notch, and therefore this point should be taken a little lateral where it is still horizontal. So it can be rotated and the C flap can be fed in the back cut and the lateral flap can be advanced. Now looking at the vermilion, look at the vermilion and vermilion border and look at the dry mucosa and a wet mucosa and what happens to this. Now look at different lips. So here the vermilion border is so very prominent and here it is not. So the prominence of the vermilion border may be different in different patients, and in some patients it may be difficult to identify where the vermilion border is ending. Where should you take the corresponding point of the highest point of the Cupid's bow? Here, if you see this Cupid's bow, this is the highest point on the right side. This is the midpoint, and here the highest point has to be somewhere here. But vermilion border here is not so prominent. So the vermilion border can be different in different patients. But what is important is you have to identify the midpoint or the central point of the Cupid's bow. Then the peak or the highest point of the Cupid's bow on a non-cleft side, and at equal distance, you should mark the highest point of the Cupid's bow on the medial aspect of the cleft. So these are the three important marking, beginning with the first, then the second on the non-cleft side, and the third on the cleft side. Then you can then mark every other point. So corresponding to this highest point, you have to make this point. And how to choose this point? I have told you one, where the white roll just begins to fade. It has not faded. And just before it turns its directions upward. So being a little lateral is always beneficial. So whether you be here or you be a little lateral. Now you see this is going up in direction. And another point is you have to see the thickness of the dry mucosa and wet mucosa and the thickness of the entire vermilion. This should match this. And the midpoint of the columella, the bases of the columella on two sides, and the bases of the ella on two sides. Now you can measure the nasal sill on a non-cleft side, and you can also measure the nasal sill on the cleft side. So the difference between the two has to be excised from the thinnest portion of the nasal sill. Now this is the node of line here. This is the junction between the dry mucosa and the wet mucosa. And you will appreciate that this is becoming thinner as it is going into the clefts. So this part, and look at this part. So this part is thinner than this, while this has to match this. And therefore, you will have to add some tissue here. So here again, you can see this is, sorry, you have to add some tissues here. So this is becoming thinner. So this thickness of the dry mucosa has to be equal to this thickness. So there is an obvious defect here. There is always obvious deficiency here. And this deficiency has to be made good by borrowing a triangular flap from this side. That will be fed here. This thickness has to be equal to this thickness. And the thickness of the entire vermilion has to be equal to this. So you have to choose a point where the peaks of the Cupid's bow on two sides and the vermilion and the dry mucosa will be of equal thickness. Not here. So this is not the point where the red one is the point where you should take the peak of the corresponding peak of the Cupid's bow on a cleft side. Now, look at this picture. The dry mucosa has been marked. So this has become thinner. This has to be as thick as this. That means you will have to bring in some tissue inside this. So that tissue can be brought from the lateral side, taking a triangular flap only in the dry mucosa from the lateral side. So the lateral side is not only providing tissue for the lip, it's also providing tissue for the vermilion. So this is how you can mark in a rotation advancement. You can make a rotation flap and a back cut, and a C flap will go there. A good muscle dissection and the triangular flap in the dry mucosa, which will be fed in the little narrower defect on the medial aspect. So this is how. So thickness of the dry mucosa is equal. Thickness of the vermilion and the free border is equal. So another important point is lip height. So height on the cleft side may be more in incomplete clefts. So listen carefully. The height of the lip on the cleft side, that is lateral side, may be more in some incomplete clefts, and height may be less in some complete clefts. So what you do, a good muscle dissection and adjustment of the tissue is the only thing that you need to do. So it can be done in nasal floor and seal area, and it can correct the defect. Now you can see the height of the lip on the non-cleft side is like red line. When you put the red line here, so the lip on the non-cleft on the cleft side, on the lateral side, is much longer than the normal side. In another patient, so if you see the height of the lip on the non-cleft side and the height of the lip in cleft side, so the cleft side or the lateral side is much longer. But you need not cut anything. You need not cut a wedge of skin from here. Just do a good muscle dissection and repair it, and it will be all right. So in this patient again, you can see the lip height. So the lip height is more on the cleft side or lateral side, but after surgery, it becomes equal. Similarly, the lip length. The lateral lip length may be shorter in some of the wide and complete clefts with marked collapse of the alveolus. But it again quickly improves with the surgery. So in this patient, you can see the lip height on the cleft side or lateral side is much shorter than a non-cleft side. But after surgery, it becomes equal. So nothing special needs to be done for these patients and these conditions. And the third most important point is a muscle repair. You can see the muscles have been bunched up on two sides. This is an obvious orbicularis bulge. So the muscle has to be dissected, and it has to be dissected wide. And all the muscle abnormal attachment to the base of the ella and base of the columella have to be separated. So this is the muscle. I am for the wide dissection of the muscle, and it can be less wide near the vermilion, and as you go up, it should be very wide. Then a Philtrum ridge and dimple correction. So this can be done by double breasting or west-over band type repair, or by horizontal mattress sutures. So the muscle can be repaired by double breasting or by horizontal mattress. So whatever you want, you can do. And by doing this, you make a good Philtrum ridge and accentuated Philtrum dimple. Another patient, the muscle has been repaired, and you see a good Philtrum ridge and an accentuated Philtrum dimple. Another very, very important point is piriform aperture incision. So this is the piriform aperture, and the lip is attached here. So the complete lip on the cleft side should be separated from the piriform aperture from the bone. Being close to the bone, you have to give an incision, go up close to the tip. So it starts from the sulcus, goes up to the tip, flush with the piriform aperture bone, and it separates the nasal mucosa from the bone. This is one of the most important dissection to bring the lateral part of the lip medially in an effortless manner, and it gives the maximum improvement in the alar flare. So it separates the nasal mucosa from the bone, and after the muscle dissection and sulcus incision, the whole unit can be brought medially, effortlessly, anteriorly, and superiorly, correcting the alar flare. And if you do this step correctly, there will be no lip which will have any tension in any of the suture lines, and you never need to give alar sulcus incision, the perinatal incisions. So this is how it starts in the sulcus and goes up to the tip, separating the entire nasal mucosa from the piriform aperture. This is very important. It starts at the sulcus and goes up towards the nasal tip like this. This is one of the most important incisions that has to be given in cleft lip, and especially the wide cleft lips. So, evaluation of the patients at the cleft. So the purpose is to know the exact deformity so that a proper treatment plan can be made and a timeline could be set. So I've told you the anatomy and all, so you have to examine everything. And when you describe a deformity, you may start from the nasal bridge, go to the dorsum, supratiparial, tip, ella, columella, the nasal sill, the lip, alveolus, palate, comment on vomer. So you describe it properly and also look for the alar webbing, the nasal septum, the soft triangle. So everything has to be assessed properly. So the ideal technique of repairing the unilateral cleft lip should be the one that facilitates the creation of a balanced lip, allows for adjustment, and produces a favorable pattern of scar. So although each method has its own merits, the surgeon should select one and complement his or her style. So anything that works best in your hands. So the principles still remain the same. Achieve accurate skin, muscle, and mucous membrane union. Here I have to emphasize once again, the deficiency is not only in the skin, it is also in the muscle and also in the mucosa. So you have to fulfill the deficiency of all the three elements. There will be defect not only in the skin, but also in the muscle and also in the mucosa. So all these deficiencies have to be filled in by borrowing tissue from the lateral side. So then you have to reconstruct a symmetrical nostril floor, symmetrical vermilion border, slight eversion of the lip, minimal scar whose contraction will not jeopardize the remaining objectives mentioned, and also preservation of symmetrical Cupid's bow and vermilion cutaneous ridge. Again, the goals are similar, and you have to get a Cupid's bow. The most visible part of the lip should be symmetrical with the apexes of the bow at the same level or on both the sides. So that's why I said the measuring the heights of the philtral ridge is most important, because you have to make the philtral ridge symmetrical and both apexes should come at a horizontal level, and any defect on the cleft side, in the medial side of the cleft, has to be fulfilled by borrowing tissue from the lateral side. Then vermilion should be full without a notch and not even a pseudo notch. And the color of the reconstructed vermilion and mucosa should match. And the scar line should be hidden in the natural skin creases, and a minor mirror image of philtral line on the non-cleft side should be made. And this is for Millards. So there should be a new natural looking philtral dimple. A central tubercle of the lip should be produced. Repair of the orbicularis muscle in proper alignment is one of the most important element of cleft lip repair. And reconstruction of a fistula-free nostril floor and an anterior palate. And the nose should be symmetrical with equal halves of the columella alar rims at the same level. No flare or groove on the nose alar basis at the same level, creating a nasal sill. No soft triangle droop and a midline septum. So all that needs to be achieved, and you should strive hard to achieve everything. You may not achieve everything in every patient, but you should strive hard for this. So coming to the Millard's rotation advancement kiloplasty. So in 1953, Millard was deployed to Korea as a surgeon with the 1st Division of the Fleet Marines in the US Navy. Now on one night while working with the prints, he noted, I had fallen asleep I opened my eyes. The photographs were standing askew. The angle of its position suddenly made me aware that what we had been searching for had been there all the time. So he realized what he had to do. So he developed a concept of rotation advancement. So thus the concept of rotation advancement technique was born. The medial part of the cleft simply had to be detached from its high attachment, that is from the base of the columella, and brought down, rotated down to a proper position so that the both apexes of the cupid's bow become horizontal and a defect is created just below the the columella, and the lateral lip advance into the gap created by this rotation. So he also emphasized that minimal tissues are need to be discarded because you can cut as you go approach, and you can use this approach, and the placement of scars are in the natural lines and they're in better respect anatomical borders. So he said it requires a fair degree of experience and a long learning curve to achieve it. And cut as you go is an explicit, I say this, that it requires a fair degree of experience and a long learning curve to achieve it. And cut as you go is an explicit admission of deficiencies in the planning rather than an ease of the technique. Because you have not planned it well. You are cutting it. It is you are increasing your incisions and you are rotating it. And when you find that it is now at a proper place, then you are bringing in tissue from the lateral side. So you're actually not sure when you are starting. And you go on cutting as you go on repairing this. So it is an explicit admission the deficiency of planning and rather than an ease of technique. But then Millard, he presented it at various places. On a medial side, he made a curvilinear incision that extends upward from the cupid's bow peak towards the non-cleft philtral column. Then downward rotation of the philtrum corrects the deformity and leaves a gap, as I've mentioned several times. An advancement of the lateral lip fills the defect and corrects the Eller flare and narrows the nostril. It was the medial rotation flap, the lateral advancement flap carrying the flared alar base, and the small triangular flap attached to the columella, which was originally advanced across the nasal floor. So now let us see the advantages of the Millards. It preserved the cupid's bow and the philtral dimple, which was very important, and it improved the nasal tip symmetry, and the scars were aesthetically camouflaged along the philtral column or ridges and within the alar trees. Since his original description was there has been several since his original description there have been several refinements of the Millard's original technique, but the basic principle of rotation and advancement remains the same. Several surgeons have advocated the addition of a small triangular or a rectangular flap from the lateral element into the lower part of the repair to provide additional length and also to break up the line of the incision and preserve the contour of the vermilion. Even I add a small triangular flap. Nodhoff and colleagues suggested a tiny jet plastic just above the skin vermilion junction to recreate the slight transferred depression normally seen just above the white rod. Now, these are some of the pictures of the incisions and the rotation and advancement. So this is rotated down, and from the lateral side, this is advanced into the defect. Now, the 3/4 of the cupid's bow is already there, but is riding high, he thought. So it can be brought down by a rotation flap on the non-cleft side. And the defect thus created be filled with the advancement flap from the cleft side. And the C flap, which results from the rotation of the non-cleft side by a back cut and incision. Now, depending on the evolution of the use of C flap, the Millard's techniques are termed as Millard 1 or Millard 2 when it is used for across the nasal sill or into the defect created just below the columella. So this is Millard 1 when it is C flap is being taken across the nasal sill, and Millard 2 when it is taken into this defect. The advantages are the flap can be modified after the initial cutting. So the Millard's cut as you go principle. The dissection is relatively straightforward and a 3-layer closure can be easily achieved. The scar mimics the normal philtral column. But the disadvantages are it is difficult to achieve a satisfactory closure in wide cleft. And the scar is a straight line and it contracts, leading to shortening of the cleft side of the philtrum. But now if you give a piriform aperture incision, you can bring even in the wide cleft, you can use Millards. And if you give a small triangular flap just above the cupid's bow, then you can break the straight line scar. So both of these disadvantages can be removed by adding up your technique, and the peri-alar incision is never ever required. So the markings, you mark the apex and highest point of the cupid's bow. This is the node of point, the lateral side as I explained you. This is the rotation and this is the advancement. You have already seen this picture. So in some of the patients, so this is the midpoint of the cupid's bow, then the highest point on the non-cleft side. This can be measured and a similar distance can be marked on the cleft side like this. So this is the peak of the cupid's bow on the cleft side on the medial aspect. So these are the 3 most important points that you have to mark. Then the midpoint of the columella, the basis of the columella and 2 sides, and the basis of the ala. So you can see these are the 3 points on the cupid's bow, midpoint of the columella, basis of the columella, and the basis of the ala. So the nasal sill on the cleft side is wider than this. You can see this is obviously. You can measure it. And you can also measure it. So this is about a millimeter wider. Then from here, you make a curve. I just forgot to mark a corresponding lateral on the lateral side, the highest point of the cupid's bow. I will mark it. So this is the curvilinear incision, goes a little up into the columella. Then there is a back cut. And a C flap has been marked. And the amount of tissue that I have to remove from the nasal sill has also been marked. Now this point has been marked. So this is a corresponding highest point of the cupid's bow on the lateral side. The thickness of the vermilion is equal to the thickness of the vermilion on the non-cleft side. Now I add up a small triangle from the lateral side. This is a small triangle about 1.5 millimeters. And then an advancement flap has also been planned. Then a small defect is created in the dry mucosa here, narrower defect, and a wider triangular flap is taken from the lateral side. So the vermilion border is cut perpendicularly. A wider triangular flap has been planned, and this goes inside. So this is the planning. This has been dissected. This is the muscle on the medial side. You can see the muscle has been dissected from the skin as well as from mucosa. This is the muscle on the lateral side. And this is how it comes. So the muscle has been repaired. And this has been closed. This small triangular flap has been fed in to a small defect that has been created by giving an incision here. So now here again, because C flap is being used here, this line comes almost similar to the philtral ridge on the non-cleft side. And there is a triangular flap here that is being fed into this. So this is the small triangular flap that will be fed into this, and this repair has been complete. When you do a Randall Tennyson kiloplasty, the principle is a back cut from the transverse incision is placed just above the cupid's bow and is used for rotation of the cupid's bow. Here, you give a back cut here, and this rotates down, becomes horizontal. And a triangular defect is created. An equal size triangular flap is made from the lateral side and put it into this. Now, advantages of Randall Tennyson is that since the measurements are done to the perfection at the beginning, there is no need to change the incision line. And also, the post-operative scar contracture and secondary deformities are minimal, as the triangular flap breaks the straight line scar. But the disadvantages are that this procedure has a visible transverse scar on the lower part of the limb. And the nasal correction has been said to be more difficult as there is no ready access. Although I do not agree to this, even in Tennyson, you have a good nasal access. And this is geometrical technique and has a learning curve. And I think it has a learning curve. Every surgical technique has a learning curve, but this can be learned easily. Now, there's so many points and that confuse the trainees. There's so many different points that confuse the trainee. The most important thing that you need to remember without going into the point, without going into the labeling system of A, B, C, D, or 1, 2, 3, 4, you have to remember the three important points: the midpoint of the cupid's bow, the peak of the cupid's bow on two sides, the corresponding peak of the cupid's bow on the left side, base of the ella, base of the columella, and midpoint of the columella. Then you have to measure the height of the philtral ridge on a non-cleft side. Compare it with the height of the philtral ridge on the cleft side and calculate the difference between the two. Now, this is the difference that you have to make good. So this line can be placed here, and to this you have to add the difference between the two philtral ridges. So that comes as an equilateral triangle here. So this height, like AB, can be placed here, and then a triangular flap can be added. This is all that you have to do in a Randall Tennyson repair, and I will show you with some of the photographs. So you need not go and remember so many different points, but you need to understand the concept. The concept is this height has to be equal to this height, and there is a deficiency. Say if it is 10 millimeters and if it is 6 millimeters, you need another 4 millimeters. So that is what you have to calculate and measure. So coming to now, so in this patient, I will be doing a triangular flap repair. So again, the markings are done. The midpoint of the cupid's bow, the highest point, and the highest point on the medial aspect, and the corresponding highest point on the lateral aspect. Now, this has been marked as a midpoint of the columella, basis of the columella, and from here you can measure the height of the philtral ridge on the non-cleft side. And from here, you can measure the height of the philtral ridge on the cleft side. Now say this is 10 millimeter and this is 6 millimeter. So difference is 4 millimeter. So you take an arc of 6 millimeter and mark it somewhere here. And then you add another 4 millimeter triangle. So that makes it 10. You measure this. You measure this. And then you measure the difference. So with 6 millimeter, you make an arc like this on the lateral side. So this is equal to the philtral ridge on the medial aspect of the cleft. you need to add another 3 or 4 millimeter, whatever is the difference between the two sides, to this. So this arch had been made. Now you take a difference of 3.5 millimeters, make a triangle, an equilateral triangle. So an equilateral triangle of 3 millimeters. So this is 3 millimeters or 3.5 millimeters, and this is 6 millimeters. So 6 and a 3.5 becomes 9.5. This was 9.5. So you need 9.5 millimeters. But the incision doesn't come here. Incision is going here. So we are retaining all this tissue. We are not discarding this tissue. This is just for measurement. This is not for giving an incision, because if you give incision here, you're losing all this tissue, and also here at the base of the ala. So I give incision close to the skin and mucosal border, discarding as less tissue as it is required. So this is the design. So you give a back cut here and a horizontal back cut here. This is not perpendicular to this. This is a horizontal back cut. So this is an acute angle. This is an obtuse angle. So give a horizontal back cut here at the highest point of the Cupid's bow on a medial edge of the cleft. Then again, the node of triangle, you have to bring it some dry mucosa from the lateral side to the medial side. So this is after dissection, the muscle dissection. And this is to show the incision in the piriform aperture. This comes close to the tip. So entire lateral part has been separated and it can now be brought medially without any tension. So this is the triangular defect. This is a triangular flap. And this is a small triangular defect in the dry mucosa on the medial aspect, and the larger triangular flap of dry mucosa from the lateral side, which is coming. So this is after the repair. And I put 2-3 sutures here to approximate the two sides of the tissues. Then there is a triple wedge technique of CBK. So like a spook, so there is a wedge here and a wedge here and a wedge here. But I won't go into the details of that. He did not publish, unfortunately. He did not publish his work. So this is, I will just show you a couple of cases with the results. So this is a rotation advancement, and this is the kind of results you get. And I have added a small triangular flap here. You can see the free border is symmetrical. The white roll is also symmetrical. There is a beautiful Cupid's bow. Thickness of the vermilion on the non-cleft side and a cleft side are equal, and nose was already good, and with the excision of about 1.5 millimeters of the nasal sill, it has become more symmetrical. Another patient with the Randall Tennyson, little wider deformity and the bigger deformity of the nose, and here the triangular flap was taken here, but again you can see the scar is not much visible, although there is some difference in the thickness of the vermilion, but overall this can be considered as a good result. So you can get good results with either of the technique. You have to perfect either one or both the techniques, and you have to pay attention to many important things that I have mentioned. Choosing the corresponding highest point of the Cupid's bow on the lateral side is very important. It is better to err 1 or 2 millimeters on the lateral side rather than on a medial side, right, where the white roll is going up. So be lateral where it is still horizontal. Then you have to match the thickness of the dry mucosa on the two sides. Bring in the small triangular flap of dry mucosa from the lateral side and feed it in the defect created on a medial side. Third, the piriform incision is extremely important. You should liberally give this piriform incision and give it up to close to the tip of the nose and separate all lateral lip elements from the bone. Fourth is that you have to do a good muscle dissection, a wide muscle dissection, especially on a lateral side, less wide on a medial side, less wide towards the vermilion, more wide towards the base of the ella and base of the columella. So when you have done a good muscle dissection, you will see that there is a defect in the muscle at the base of the columella. And that defect also has to be filled in by bringing in muscle from the lateral side. So you have filled in the defect in the skin, you have filled in the defect in the muscle, and you also have to fill in the defect of the mucosa. And then comes the no. So with this, I come to the end of this talk, and if there are questions, I will be very happy to answer those questions. Thank you.
Thank you very much, sir. It was one of the best talks on a very comprehensive talk on cleft. I think you've dealt with all the various techniques. All the questions that an examiner usually asks about cleft lip, you have actually covered it. Very nicely, you have been able to cover. Sir, good evening, sir.
Good evening.
Good evening, sir.
Good evening, sir.
Good evening.
So now we have the president and the secretary. Both of them are there in the same meeting.
Yes, yes.
So it was an excellent talk.
Thank you,
With
sir.
all
Good
the
evening, Bhattacharya
Good
sir.
evening. Good evening.
Good evening, good evening.
Sorry, I am little late to join,
No
but
problem.
wonderful talk, sir.
But I was unable to join actually.
So, really a wonderful talk, sir. And we
Thank you so
covered
much.
all the basics which usually asked in the question, and very practical way, and with clinical material and demonstration of what all required for a cleft. Really wonderful talk, sir.
Thank you so much.
just one question, sir.
Yes.
Because all of us were trained in actually Millard's Rotational Advancement Flap 1 and 2. But off late, I see that many of the younger people, they prefer to actually go for other techniques. What is your take on this, sir?
I was trained in both Millards as well as Randall Tennyson during my residency. So I do both of the techniques, but of course over the years both the techniques have been modified a bit, right? So when I do a rotation advancement, I make it a point to add a small triangular flap.
All fine.
That's a very important thing.
Yes.
It is not visible, but it certainly breaks the straight line and the scar line contracture that I used to have in my own cases when I was doing rotation advancement are much less or negligible now. And in triangular flap also, I try to keep the triangular flap is smaller. If it is more than 4 millimeters, we are not probably measuring it correctly. So, and it will show. So, triangular flap also the flap size has to be 4 millimeter or less. I'm talking about the children who are less than 1 year. So, otherwise you have to adjust the tissues and make a symmetrical link. So there are other techniques, FIFR and other techniques they're there. So, but I still prefer rotation advancement with a small triangular flap, and I do a Moeller's modifications. I go into the columella and then give a back cut and use my C flap into that defect. And there is never ever a deficiency of nasal cell tissue. So there is enough tissue available at the base of the ella and at the base of the columella. There is absolutely no need to bring any tissue there. But when you are repairing the nasal cell, so the muscle has to be repaired right up to the nasal cell area. So this will give it a well form. And then you have to give a subcutaneous sutures also in the nasal cells, right, before giving the skin suture. Otherwise, what happens if there is no support of the muscle there, the nasal cell will go down. Or if you have not given a subcutaneous suture, it will go down and will appear like a notch. Right? Similarly, another point is that when you are giving a muscle suture, so the most important suture is the muscle suture at the peak of the Cupid's bow area. Skin suture is not my key suture. Muscle suture is my key suture. Then finally, I give a muscle suture in the pars marginalis, that is in the vermilion area on two sides. So that suture is very important. Suppose this is the vermilion, thickness of the vermilion, and upside there is a lip. So if you have not given a suture here, the mucosa will tend to invaginate like this, and it will become a notch there. So you have to support that mucosa firmly with the muscle sutures there. So there will be no notch. So even if you have measured properly, you have you have taken good flaps, and if you have not sutured the muscle, the mucosa will invaginate like this and give it an appearance of notch.
How often do you do do you do the primary rhinoplasty in all cases nowadays, or you keep it for a second later on?
Okay, that's a good question. So I do a closed primary rhinoplasty in all cases. I do not expose the cartilage, right? So see, to get a good nasal shape, to get a good alar shape, there are 2 or 3 things which are very important, right? And 2 of them are not related to nose, right? So one, that you have to dissect the muscle very well. You have to separate muscle from the base of the columella, right? And from the lateral side base of the ala as well. Now, when you repair the muscle from the lateral side to the medial side, right, the lateral muscle is being sutured at the base of the columella. You can even take a hitch from the base of the columella tissue there. It will immediately straighten the columella. So the part of the nose is already corrected, right? When you're taking an incision, I explained that you have to take an incision from the piriform aperture. You have to separate the entire nasal mucosa from the piriform aperture up to the tip of the nose. When you do that, and when you go wide, the entire lateral part of the nose, with the base of the entire ala, right, comes medially. So it is wide like this, and when you do it, it comes medially like this. So then about 60-70% of the alar flare is corrected, then the nasal deformity is corrected, then you do a close dissection into the columella, go above the lateral crest of the alar cartilage on both the sides, and then bring them medially, right? So by doing this, 80-90% of the nasal deformity is corrected. Sometimes what I do is I give a close suture from both sides of the nostril, starting from one side, go on the other side and bring back. And then I suture the alar cartilages together, right? So in the tip area. So that gives a rounded peak shape. So I do not expose the cartilage. I never do dissection on both sides of the cartilage, never ever, right? So, and I also am a strong believer, no matter what you do in the nose and nasal cartilages, if you have not dissected and repaired the muscles well, if you have not separated nasal mucosa from the piriform aperture, and if you have not given the cinch suture, your nose will never appear normal. That's my firm belief.
Do you do thin sutures? From the LR base, you take sutures?
I do.
Cinch.
See, my lips, whatever the width of lip is that, I mean, for me, no lip is too wide to be sutured in a tension-free manner. No palate is too wide to be sutured in a tension-free manner. Your dissection has to be good.
The nose, by piriform aperture, you go all the way right up and then separate all the muscles that are there from the side.
That's right. all the mucosa, skin, everything from the piriform aperture I separate. Then I go laterally in the sulcus area and I separate muscles from there. I do not do a subperiosteal dissection. I do a supraperiosteal dissection and I separate muscles from there. The entire nose comes from lateral side to the medial side in one block. But then I separate the muscle from the base of the ala as well, because that's an abnormal insertion and that is pulling the ala laterally. Similarly, the muscle is pulling the base of the columella on the non-cleft side. So both the muscles separate and repaired well, the columella becomes straight. The ala, lateral part of ala comes easily medially with a cinch suture and the piriform aperture incision and some sutures in the nose and a close dissection in the nose. The work is done.
Thank you. Wonderful. Dr. Farooq, good evening.
Good evening, sir.
So, I don't think there are any questions in the chat box. Dr. Ritchie, any questions, Dr. Ritchie?
Sir has explained so excellently. Actually, lip is covered totally for the PGs and even we learnt a lot, sir.
There is one more point that I wish to mention. It's about the frenulum of the lip. I always cut the frenulum because that is the tethering point, right? Always cut the frenulum. What most of the students do not understand that the deficiency is in all the three elements: skin, muscle, and the deficiencies in all the three elements have to be corrected by borrowing tissue from the lateral side. So in a skin, you are either creating a defect on the base of the columella region or just above the Cupid's bow. In the muscle, when you separate it from the base of the columella, there is a defect there. You bring in the lateral tissue, and after you have done this and you have not cut the frenulum, you will find that it is still holding. The moment you cut the frenulum, the lip falls nicely. And there is a defect of the frenulum area. You can bring in the lateral mucosa there and fill it in. So unless you have created and reconstructed defect in all the three elements, your lip will not become natural and normal.
May I ask a question?
Yes, sure.
Good evening, everyone. It was a wonderful presentation. At the outset, I would say that really exhaustive. I want to ask about what is your take on microform cleft or the minor cleft UTC? You advocate with the formal repair of the same or?
Yeah, it's a very good question. See, repairing lip is, as you all agree, is an art, right? And of course, based on sound science, right? So you have to assess. So the most of the incomplete cleft lips are to be repaired as complete cleft lips. That's my statement. But then if there are microform lips, right, and the muscle is intact, the muscle may be flattened there, the filter ridge may not be prominent, right? So you can still do just the skin repair with a small triangular flap if required, a small triangular flap required in the vermilion, repair the mucosa, and as far as the muscle is concerned, you can just flick them so that it mimics the filter ridge. But if there is a deficiency in muscle, and if there is a difference in the heights of the two filter ridges, you will have to do a formal, complete cleft lip repair, in more often than not. So many incomplete cleft lip are deceptive. In fact, the severity of the cleft lip is not because of the width of the cleft, but it is because of the difference in the heights of the filter ridges. So even in incomplete cleft lip, if the difference in the philtral ridge is too much, it's a severe cleft, even if it is incomplete and narrow. So for me, a severity of cleft lip is defined by the difference in the height of the philtral ridges, not of the width of the cleft. Now, in earlier time, when they were not giving the piriform aperture incisions, when they were not giving a good muscle dissection, wider cleft were considered difficult to repair. And you would remember the perialar incision was a norm, because how else would you bring the ala medially? But now with the piriform aperture and a good muscle dissection, bringing the ala medially is not a problem at all. So the problem what remains is making the philtrum symmetrical and the cupid's bow horizontal. So for me, the difference in the philtral ridges, in the heights of the philtral ridges is important, and that corroborates with the severity of the cleft, not the width of the cleft itself.
Great, sir. Nicely explained. I am highly delighted that, and it's a proud moment that your guru is also here, sharing the same guru and Shishya together. It is really a proud moment for the Bhattacharya sir too.
Everything I've learned from him, and he gave
I am
me all
highly
the basic
delighted.
concepts so well.
From the heart, I am highly delighted that both sharing the same dice. It's a
Yes.
proud moment for the guru also.
Yeah.
Really a proud.
Well, I feel that it was a very detailed, meticulous presentation by Dr. Subodh.
Really,
And
sir.
from his vast experience, he ascertained many practical clues to the audience and trainees. And as you all can appreciate, I proudly loved his deliberation. Very proud of you, Subodh.
Thank you, sir. Thank you so much, sir. And I'm very grateful for this opportunity given to me for contributing to the cause of trainees in plastic surgery.
Wonderful presentation. Sandeep sir, you are muted.
No, I
Actually,
was
very
just
short time is given, sir. Sir accepted immediately when I asked. Thanks a lot, sir.
Thank you. Thank you. It is my pleasure.
we hope to tap more of your potential again in future Plastiquest programs also, because you are
Sure.
a vast reservoir of knowledge.
Yes.
Yeah, I will very happily present wherever you want on whatever topics, right? So I will be really obliged for those opportunities given to me.